Okay. So our learning objective is to become better familiar with relevant anatomy of the shoulder, to understand the anatomic basis of shoulder disease, and to improve our surgical practice. By reason of introduction of the shoulder, it's the articulation between the scapula, the clavicle, and the proximal humerus. We also need to mention that the rib cage thoracic component to it. Therefore, there are four joints in that make up the shoulder girdle. The glenohumeral joint, which is the one we all think about when we talk about the shoulder, the acromioclavicular joint, the sternoclavicular joint, as well as the scapulothoracic. Now, the injuries that we see are common and can be debilitating, and an adequate knowledge of the anatomy of the shoulder is important in knowing how to address these various injuries and pathologies that we see with respect to the shoulder joint. So this shows you basically a basic picture of the shoulder joint with this opened up, and this is the humerus, with the head of the humerus and the articulation with the glenoid cavity, which is an aspect of the scapula. We'll go to this in details, but it's just to show how it is. And for many people, the shoulder anatomy is a bit complicated or complex, and many of us find it difficult to get a proper understanding of the shoulder. So we'll start first with osteology and take it bone by bone. And first, we'll take the scapula, which spans the second to the seventh ribs and has an insertion of up to 17 muscles in it. Is anteverted on the chest wall at 30 degrees to the body, and the glenoid is retroverted 5 degrees relative to the scapula. Is the site for the glenohumeral as well as the acromioclavicular joints. In this diagram, we'll look at the scapula from the anterior aspect, where we'll see that the projections will include the coracoid process anteriorly, the acromion there posteriorly, as you can see, as well as the glenoid fossa through which the humerus articulates, giving rise to the glenohumeral joint. The acromion is the continuation of the spine posteriorly, and we know that the condition called os-acromially, which is the incomplete fusion of the secondary ossification centers of the acromion, can sometimes occur as a painful condition, and which might require, if pain persists and non-operative care doesn't suffice, may require internal fixation or excision, as the case may be. The coracoid, which I'll show back again here, is an important articulation of the scapula, because it's on this is a central theme when you're dealing with the approach to the shoulder. This coracoid process is the insertion point of the conjoint tendon. Conjoint tendon is made up of the short head of the biceps as well as the coracobrachialis. We also know that the coracoacromial ligaments and coracohumeral ligaments are attached here. The brachial plexus is quite intimately related to this structure, and when we approach the shoulder, particularly in the deltopectoral approach, we go towards the coracoid process to center us, knowing fully well that anything medial is relatively dangerous because of the neurovascular structures that we find close to this. So we know that the coracoid process is important in our surgical approach. Secondly, is that this piece of bone is useful when we do the lateral approach, where we can osteotomize the coracoid process and mobilize it together with this conjoint tendon to the inferior glenoid fossa as a sling and a means of stabilizing the shoulder in recurrent anterior shoulder instabilities. On the posterior aspect of the scapula, we see the spine, which I had said earlier, the spinous process of the scapula, which projects onto the acromion laterally. And then we know that above the scapula, we have the supraspinatus fossa from where the supraspinatus muscle arises, and inferiorly, the inferior spinatus fossa where the inferior spinatus muscle arises. The scapula carries the glenoid fossa, which we had mentioned earlier. One important thing I want to mention in regards to the anatomy is the pathway of the suprascapular nerve in the suprascapular notch. And that's where my cursor lies, showing the suprascapular notch. In this notch, you find that the suprascapular nerve is separated from the suprascapular artery. And so the suprascapular artery is superior. The transverse scapular ligament lies between them, and the suprascapular nerve is inferior to it. So the artery is superior to the nerve in the notch. And when you have impingement of the suprascapular nerve at this point, it leads to pain and affectation of both the supraspinatus muscle and the infraspinatus muscle. But as the nerve transverses on the scapula down here to the spinoglenoid region, if there's an impingement at this point, the nerve supply to the supraspinatus has already been given. So the only affectation you will find at the spinoglenoid ligament region or a spinoglenoid obstruction or impingement is that to the infraspinatus muscle. We do know that at the suprascapular notch could have things like callus formation, and etc., impinging on the nerve. Whereas when you have labral cysts, particularly with the superior labrum, which is intimately attached here, you could have labral cyst formation from labral detachment, which will impinge upon the nerve and giving rise to pain. So that's a very important anatomy that we need to put in mind when we're looking at the shoulder. In addition, also, sometimes patients have very intractable shoulder pain for which maybe a subacromial steroid injection does not suffice, and you want to help in pain control. A suprascapular nerve block is particularly useful in helping to obviate pain in the glenohumeral region and around the cuff tendons. So knowing this anatomy will help you to address the nerve and where your injections would be inserted. Usually you could use anatomical landmark method, or you use ultrasound guided method. That is not in the purview of this lecture, but just points out something in relation to the anatomy. The glenoid is the lateral projection of the scapula, and its socket is deepened by the labrum. In this diagram, we try to see that deepening of the scapula. This labrum is a fibrocartilaginous thickening. We know that the labrum itself is pear-shaped with an upward tilt of 5 degrees and a 7 degrees retroversion to a 10 degrees antiversion. And this essentially ensures that the glenohumeral joint is the most mobile joint in the body, and so is not particularly the most stable, and so requires or relies upon stabilizers, which we will discuss, both static restraints and dynamic stabilizers, to ensure that the joint is stable. So as you can see quite clearly, this joint is dislocatable as opposed to some other joints in the body. I'll talk about the clavicle. The clavicle acts as a strut that connects the axial skeleton here in the middle with the appendicular skeleton. And so it connects the scapula to the sternum. And its articulation, it has a double curvature. It's the first bone to ossify at 5 weeks of gestation, and the last to fuse, where the medial epiphysis at 25 years is the most common musculoskeletal birth injury. We know that its articulation here at the acromioclavicular joint and its articulation here at the sternoclavicular joint ensures that it connects the two aspects of the human skeleton adequately. The proximal humerus was retroverted 30 degrees relative to the transepicondyal axis. Its anatomical neck is directly below the head with a capsular attachment, and surgical neck is more distal and site of most of the fractures. We know that the rotator cuff muscles attachment are to the humeral head, and while the supraspinatus, infraspinatus, and teres minor, SIT, are attached to the greater tuberosity, the subscap is attached to the lesser tuberosity. We also need to know about the bicipital groove in which the long head of biceps lies. This is important when we are dealing with shoulder pain, with anterior pain generators, because tenderness over the bicipital groove gives you an indication of an inflammation of the long head of biceps. And that can easily be addressed either with a bicep tenotomy or a biceps tenodesis. The attachments of the rotator cuff muscles are important with regards to cuff tears, as well as when we are approaching the shoulder, because the subscap needs to be detached at some point to get access to the glenohumeral joint. So again, back to this diagram, and we'll see this pear-shaped glenoid with the deepening, with the fibrocartilaginous deepening called the labrum. And we know that here, the long head of biceps is attached at the most superior aspect of the glenoid. And so it's intra-articular at some point. And therefore, we know that pathologies of the long head of biceps can give rise to shoulder pain as well. We would look at the articulations of the acromion and the coracoacromial ligaments with the coracoid process. And looking at this, you can see that the tendon here lies underneath the arc created by the acromion and the coracoid process via the coracoacromial ligament. Therefore, if there's any impingement, bony spur, if there's anything that reduces this potential space, it leads to tendon impingement. And sometimes also where this tendon is inflamed, it gets swollen and then starts to rub against the acromion, and we have the tendinitis, and then you have the cuff tears and all of that. The discussion on whether the tears are intrinsic or extrinsic will be discussed when we're talking about cuff pathologies, but it's important to look at that closely where my cursor is. Look at the supraspinatus tendon right there below, and above it is the subacromial bursa, and that's the acromion there, and then the coracoacromial ligament connecting with the coracoid process right there. The glenohumeral joint is a ball and socket joint, and its greatest range of motion. So I'm discussing the various joints in the shoulder girdle now. I'm taking them one by one. And like I said before, the labrum deepens the socket by 50% and is helping to improve the stability of these very, very mobile joints. In this labrum deepening, there are anatomical variants which we must be aware of: the sublabral foramen and the Buford complex. I'll start with the sublabral foramen. So again, here this is the pear-shaped glenoid. The white you see here is the labrum all around, and then anteriorly between the 1 and 3 o'clock, you can see what appears to be a labral tear. And so you could, for beginners who do an arthroscopy, you could see this and consider this as an anterior labral tear and would want to repair it, and consider as part of your biceps tendon pathology. Any repair of this sublabral foramen will lead to a restriction of external rotation. Therefore, you must be aware of these normal variants that we see. A magnetic resonance arthrograph would give more information about it. And here we can see the differences between a slap tear and a sublabral recess. The signal extends medially and follows the contour of the glenoid cartilage, whereas in the slap tear, it extends laterally. Usually, the sublabral foramen recess you would see on the arthrograph is less than 3 millimeters. But with a slap tear, the tendency is that it can increase to be more than 3 millimeters and is located usually at the biceps anchor. The second thing that we can miss is what is referred to as a buffered complex. And in this case, it's a defect, a total defect. So the labrum is incomplete. It's not a tear. The labrum is incomplete at between 1 and 3 o'clock, and there's a thickening of the middle glenohumeral ligament complex. So those two anatomic variants of the labrum must be recognized when doing arthroscopy of the shoulder so that one does not repair what's the normal variant. I had said before that the glenohumeral joint is a very, very mobile joint, and so it requires restraints to confer onto it some degree of stability. We have static restraints of the articular joint as well as the dynamic restraints. The static restraints first includes the articular anatomy, which we've discussed, the orientation of the humeral head with the glenoid on the scapula, the glenoid labrum, which deepens that glenoid to increase it by as much as 50%, and then the glenohumeral ligaments, and there are 3 of them: superior glenohumeral ligaments, middle glenohumeral ligaments, and inferior glenohumeral ligaments. These act as restraints to the shoulder at various positions of the glenohumeral joint. Finally, you have the capsule and then the negative intra-articular pressure that acting like a suction of the cup onto the head of the humerus. Dynamic stabilizers will include the rotator cuff and the biceps tendon, and that's very important to note because the rotator cuff prevents superior migration of the glenoid, and by so doing, of course, helps to stabilize the shoulder joint when the deltoid muscle is activated. So when we have cuff tears and large cuff tears, what essentially happens is that the humeral head migrates, and then will through a series of processes, leads to what we refer to as a cuff arthropathy, and we'll have arthritis of the glenohumeral joint. I want to look at each of the glenohumeral ligaments and talk about the points at which they act or give their restraints. The superior glenohumeral ligament restrains an external rotation in the adducted arm. That is, your arm by your side, the superior glenohumeral ligament is the one acting the most. If you try to externally rotate with the arm by your side, superior glenohumeral ligament is put into action. When you are at 45 degrees, then anterior translation, so 45 degrees elevation, anterior translation is restricted by the medial glenohumeral ligament. And then when you are at full abduction, 90 degrees of abduction, and external rotation, like so as I'm describing in the video, in that position, you have the anterior band of the inferior glenohumeral ligament put into action. This is the position of when you're doing the apprehension test. When you do your apprehension test, you're trying to find if the shoulder dislocates in this position. External rotation and abduction to 90 degrees, and you see that. What restrains that is the inferior glenohumeral ligament, the anterior band. And that tells us that when we have recurrent shoulder dislocation, that the inferior glenohumeral ligament's anterior band has been affected. And it's not just a case of maybe a bony lesion or all the other things we talk about when we talk about shoulder instabilities, but the inferior glenohumeral ligament is also involved. The posterior band restrains posterior and inferior translation with the arm internally rotated and adducted to 90 degrees, so like so. Okay, so the acromioclavicular joint is the next most important thing when we're talking about the joint, when we're talking about the shoulder girdle. It's a plane and gliding joint. At maximum elevation, 5 to 8 degrees of rotation is possible. So there's some degree of movement. that occurs there. And this is the, so looking at the diagram again, to get our orientation right, the scapula with the glenoid, the humeral head, and proximal humerus. And then there is the clavicle there, like so. And this is the coracoid here. And then that's the acromion, which is the lateral projection of the spinous process of the scapula. And so this is the acromioclavicular joint. And the acromioclavicular ligaments prevent anterior-posterior displacement. But it's important to mention these ligaments, the coracoclavicular ligaments, which are made up of the conoid and the trapezoid ligaments. The conoid is the stronger of the two. These prevent superior migration of the clavicle. Therefore, when we have the AC joint injuries, which the Rockwood classification 1 to 6, you will have disruption of this, the acromioclavicular ligaments, as well as the coracoclavicular ligaments. And the various disruptions is what gives rise to the various classifications of the AC joint disruption by Rockwood. So it's pretty easy to remember that the AC joint prevents the anterior-posterior, while the CC joint and ligaments prevents the superior migration of the clavicle. The sternoclavicular ligament, again, is double gliding with articular disc. Very little movement occurs there. The sternoclavicular ligaments, as well as the costoclavicular ligaments, are responsible for stability at this point. There's not much to say other than this is the point of transmission of the strut action of the clavicle to the thorax. The scapulothoracic joint is not a true joint, and it just allows scapular movement against the posterior rib cage, positions the glenoid for glenohumeral movement, and acts as muscular attachment to fix the joint. So when we're talking about the muscles around the shoulder joint, we'll be looking at this diagram, and there we'll see that, and I will talk about that later, that we described 4 layers of the surgical anatomic layers of the shoulder, but let's stick to basic anatomy. And we know that we start with the deltoid here, anterior, covering laterally and anteriorly, and then we have the pectoralis major here. And what lies at the landmark between these two muscles is the cephalic vein, which we will discuss when we're talking about the deltopectoral approach. The deltoid muscle is attached to the lateral aspect of the clavicle and to the acromion as well. And then that's from the insertion, the origin, and its insertion is down here on the humerus. We need to split the deltoid to then go further in to see further other muscles and at play over the glenohumeral ligament. So the glenohumeral joint. Then I'll also need to mention that this is the deltoid. The deltoid has, the biceps brachii has 2 heads, the short head and the long head. The long head comes this way like so and goes into the glenohumeral joint. It has an intra-articular extension. The short head goes to the coracoid process, and together with the coracobrachialis forms the conjoint tendon that's attached to the coracoid process. So I'm looking deeper into the joint. Posteriorly here, you see the supraspinatus. And supra simply is above the spine, infra below the spine, and then at the very edge of the scapula, you have the teres minor. And what we see with the supraspinatus is that it passes underneath the arc of the acromion and then goes to be inserted into the greater tuberosity of the humerus. And that you see again here, that's the supraspinatus there. And when there's impingement, this is the commonest location for rotator cuff tears. The commonest tears are those of the supraspinatus and the subscap. And this is the location of the tear, because this area is relatively avascular, and repeated micromotion against the acromion or against any bony spore here would lead to tears of the supraspinatus. The other thing to see here that is anteriorly is that the subscap lies anteriorly and is attached just medial to the bicipital groove. And this is the bicipital groove, like so here. And when we need to get access to the glenohumeral ligament, the subscap has to give way. We'll have a conversation on how to go about this to ensure that we do not lose the function of the subscapularis, because if you transverse this muscle and repair like so, scar tissue forms, and then there's a loss of external rotation. Now, I want to look at the nerves around the shoulder girdle, and three nerves are important to us: the suprascapular nerve, the musculocutaneous nerve, and the axillary nerve. The suprascapular nerve I have discussed earlier, but we can trace it coming up there, passing the suprascapular notch on the scapula, and passing inferiorly down here to the splenoglenoid region, and giving off fibers above the spine to the supraspinatus, and inferiorly here to the infraspinatus, and also to the joint, giving articular branches to the joint. And like I described earlier, a block of this nerve can help with pain in the joint. Impingement can occur at the spinal suprascapular notch or at the splenoglenoid region, and the implications are different, because impingement at the notch would affect both supraspinatus and infraspinatus, while impingement at the splenoglenoid region affects only infraspinatus. Also like to mention the axillary nerve. The axillary nerve is at risk somewhere at the inferior border of the glenoid, and this region referred to as the quadrangular space, bounded superiorly by the teres minor, inferiorly by the teres major, medially by the long head of biceps flexor, and laterally by the humerus. And it contains the axillary nerve as well as the posterior circumflex humeral artery. And the nerve comes out through this quadrangular space and runs right across the humeral diaphysis, and where it's at risk of being injured when you make incisions on the deltoid greater than 5 cm below the acromion. This is at risk of injury in the lateral deltoid split approach, as well as when you have anterior glenohumeral dislocations, then you have axillary nerve could be involved. The last nerve is the musculocutaneous nerve, which usually lies, it's not in this diagram, which usually lies in close approximation to the coracobrachialis. It's 5 to 8 centimeters inferior to the coracoid process. And so when we mobilize the coracoid process or the coracobrachialis or the conjoint tendon, we must be careful where you put your retractors so that you do not damage the musculocutaneous nerve. Finally, I would like to talk about the rotator interval. This is the interval in which you come in arthroscopic approach, and it's also a useful interval in repair when dealing with instability. And it's bounded by the coracoid process medially, and then supraspinatus superiorly, and subscapularis inferiorly. And this is where the anterior portal of the in the shoulder arthroscopy will come in through, and via instrument portal what you work with. And also sometimes we tend to want to close this rotator interval when we're trying to address recurrent shoulders instability. Okay, sorry. So conclusion about the shoulder, as we've gone through the osteology, the joints that you find in the shoulder, the nerves, blood supply. While preparing for this lecture, I saw this tweet which says, can we all please agree that the shoulder is the worst joint? This is absolute nonsense. And then there were so many comments that followed. And what came to me was the fact that a lot of people across the world find the shoulder as a pretty complex joint to deal with. But what I've tried to do this afternoon is just break it down into simple bits and look at the surgical aspects that concern us. And then we can easily identify the anatomy that concerns our surgical practice without burdening ourselves with things that are not particularly important. So basically, it's not a difficult joint to understand when we break it down to the glenohumeral, the acromioclavicular, as well as the other two not so significant joints. And then knowing fully well where the nerves pass, the landmarks for the vessels, and what we can do with regards to approach or with regards to pathology. Thank you for listening.
Thank you very much. I wonder if people have any questions, and they can start putting this up into the chat boxes. Meanwhile, Dr. Alabi, who is moderator for the day, is in the house. He's also an arthroscopy surgeon, but based up north in Kano, and he would be moderating the question and answer session. So I do welcome you, sir. Thank you for your absolutely beautiful.
Sorry, Dr. Lawan, can you hear me?
I can hear you. Can you hear me?
Yeah, I can hear you clearly, because I'm seeing some people saying that they couldn't hear at all. So I was wondering.
Oh, I think we sorted that. He wasn't logged into the audio at all. He had only just connected to Zoom without logging into the audio.
Oh, I'm so sorry about that.
Yeah, so we did ask him to either connect to the audio or to log in again, because sometimes that's just easier. I'll try and find him and see if it's been sorted. Just to thank you for the very beautiful part one of this lecture, and to ask if people have questions and answers, and then I can hand over to Dr. Alabi to moderate the Q&A session subsequently. Or would you like to take the approaches and then take all the questions at the end, your preference?
Well, if there are no questions, we can go on to the approaches. The approach is not so long, because quite clearly, approaches is like opening the door to a beautiful building. You need to know what you're doing in the building. So what you do subsequently is the real meat, and that can be discussed when we discuss the various pathologies. But it's like an intro. We could go ahead and do that. Maybe that will give us some room for more conversation.
Okay, in the meantime, I think Dr. Yongu still hasn't logged into the audio. Same with Dr. Arthur, so I'll just send them private messages again and try and talk them through. Over to you, Dr. Tapo.
Oh, okay. So thank you. So approaches to the shoulder. This is quite interesting, because as a resident, it was like a mystery, and it was pretty difficult understanding the shoulder. It seemed like everybody avoided the shoulder. It was like something that was a no-go area, but that's not true. It's pretty straightforward and easy. And so we're just going to go through it and see if there are any questions subsequently. Basically, we'll be talking about the open and minimally invasive approaches. Again, it's all dependent on good knowledge of the relevant anatomy, so as to avoid injuring important structures, neurovascular structures, and also knowing how to repair, how to approach so that your repair is adequate when you're closing and doesn't cause significant morbidity to the patient. Because sometimes you find people who do shoulder surgeries for instability, for example, and then at the end of the day, the patient has gross restriction of external rotation. And that that is not helpful at all. And that's down to approach and knowing what to do or what to touch and what not to touch. With the shoulder, more than any other part of the musculoskeletal, any other part in orthopedics, arthroscopy is increasingly taking over the function. So really all that is left now is fractures and arthroplasty. Every other thing that we can do open is being done arthroscopically. And that is it's important for us to know that with the shoulder, the approaches are both open and minimally invasive. I'll start by talking about the anatomic layers, which Cooper et al. Described. We say that 4 layers, surgical anatomic layers of the shoulder. The first layer is consists of the deltoid, the pectoralis major, and the trapezius. That's what you see first when you do either the deltopectoral approach or the deltoid splitting approach and get past the subacute. You will get either the deltoid or the pectoralis major or both of them. When you go beyond them, the next level, the next layer will be the clavipectoral fascia and the conjoint tendon that's attached to the coracoid process. This conjoint tendon is made up of the coracobrachialis and the short head of biceps. That's the next layer. When you go beyond that layer, you would get to the rotator cuff. Anteriorly, it will be the subscapularis that will be in your way, and superiorly, you have the supraspinatus, and if you go beyond that, you have the infraspinatus. And also, if you go as far to the acromion, you have the subdeltoid bursa, which is usually exercised when you're doing the subacromial decompression. And once you take away this layer, what you have is the glenohumeral capsule. What you do then subsequently will be dependent on the indication for your procedure and what you are there for. I'll start with the open approach and start with the deltopectoral approach. This is an extensile approach. It's the workhorse of shoulder surgery, and all shoulder surgeons know a deltopectoral approach. It is internervous between the axillary nerve that supplies the deltoid and the pectoral nerves that supply the pectoralis major. However, like I said earlier, indications for its use are increasingly reducing. Will just essentially be limited to doing arthroplasties, fractures of the proximal humerus, and then open latissier procedures, which even now is being done arthroscopically by some surgeons. So indications will be already for the proximal humerus, arthroplasty, bony glenoid injuries, where you have fractures, bony bancards, open latissier for instability. And you could use this approach to do a Bankart repair using the open method if you do not have the skill or facilities for the arthroscopic Bankart repair. You could also use it as an approach to address the biceps tendinitis, to do a biceps tenodesis, capsular shift in either posterior capsular shift or anterior capsular shift with the instabilities can also be done in an open approach. But as you can see in this list here, only 2 things here can be done arthroscopically: ORIF of the proximal humerus and arthroplasty. Every other thing on this list have been addressed at this point with arthroscopic approach. The technique for this is a modified beach chair position, which patient is supine and you have the upper body elevated for about 20-25 degrees. You can choose to put a sandbag on the medial aspect of the scapula. Some choose not to. Drape the extremity free so you can have access to the upper limbs and you can move, because at some point in your approach, you will need external rotation to improve your access and improve your visibility. I tend to infiltrate the line of incision with adrenaline. That helps to reduce bleeding and helps to allow me to keep things anatomic because I need to look for the cephalic vein. With experience, you do not need to do that. You would get easy access and go right all the way through. The incision is, the skin incision starts from, so you feel for the coracoid, okay? It's from the tip of the coracoid and follow all the way down towards the axilla, okay? Like you're doing a Henry's approach. This skin subcute is in the line of the incision. You divide the subcute, separate the subcute, so that we get to the first surgical anatomic layer, which is the deltoid and the pectoralis major. What I tend to do sometimes, with bulky, with obese patients or fat patients, you might miss your way and your initial incision is not exactly where it should be. What you need to look for is to look for the cephalic vein. And the easiest way to find the cephalic vein is to look for the fat condensation. So you're seeing muscles, you've gotten to the first surgical anatomical layer, look for fat condensations. Where the fat condensation is, the cephalic vein lies underneath it. And then you have your plane through which you work. And that's the cephalic vein there. So you have the deltoid laterally and the pectoralis major medially. So once you've gotten this, you need to split the deltopectoral junction by blunt dissections. There's a tendency to have the vein. So the question is, which way do you retract the vein? Do you retract it medially or retract it laterally? Depending on which literature you're reading. Some would say you retract laterally because there are fewer vessels you need to ligate. Some would say, oh, retract medially. Some other authors would say, allow the vein to choose for you. What I tend to do is to allow the vein to choose for me. Which direction it tends to tilt towards is where I will retract it towards. And once you've retracted the cephalic vein, by blunt dissection, split open the deltoid and the pectoralis major and create a subtectoral flap and a subpectoral flap, and then put a self-retaining retractor in that space. What then you will see is a clavipectoral fascia, and we will see the coracoid process right there in front of you. So the clavipectoral fascia is incised. The point of incision is from the tip of the coracoid process, staying laterally. Ensure that you're always lateral, because on the medial side, you have important neurovascular structures, including the brachial plexus. So stay laterally and split the clavipectoral fascia, and then you then have the conjoint tendon to address. Now, depending on the procedure you're carrying out, if you're going to the glenohumeral joint, sometimes some people would osteotomize the conjoint, the coracoid, and then for ease of exposure. And then at the end of the procedure, we'll go back and fix it back. If you're going to do that, ensure that prior to your osteotomy, you have made your drill holes across the point of osteotomy, so that when you want to fix back the coracoid process back into place, you're not going to have a difficulty and having an added morbidity of a non-union of your coracoid process. So for ease of access, many people would osteotomize the coracoid process, and the conjoint tendon moves together by blunt dissection. You flip that away, and what you find underneath the conjoint tendon is the subscapularis. To get better view of the subscapularis, you need to externally rotate the arm. And then at the inferior border of the subscapularis, you have vessels there which are coming from the anterior circumflex humeral artery. These need to be ligated. We also need to know that we try not to go beyond that area where the vessels are because of torrential bleeding that will occur. So if you stick above that, you may not even need to ligate those vessels. However, to get to the glenohumeral joint, the subscap must be retracted or must be cut. And that's where the controversy, well, not exactly a controversy, that's where decision-making comes in. So you could do a longitudinal incision right there at the lesser tuberosity of the subscap and flip medially. And then all you have underneath is the capsule of the glenohumeral joint. And then you can go ahead and address that and get into the glenohumeral joint itself. If you to do this, it is important to put stay sutures so that when closing, one does not inadvertently imbricate the subscap. If that is done, then you are doing a putty plat by error. And so you will lead to a patient having significant loss of external rotation at the end of the surgical procedure. What is advocated today is either the L-shaped approach or the transverse split approach. In the split of the subscap, what that ensures is that at the end of the procedure, all you have to do is just put the fibers together and put 1 or 2 or 3 stitches and you're good. And the integrity of the subscap is not affected. Patient can begin immediate physiotherapy because you're not waiting for the muscle to heal, and there is no risk of loss of external rotation. To do this transverse split, you divide the subscap into 3/3. So it's an upper 2/3 and lower 2/3. At that junction is where you make your transverse split. This tends to be my preferred approach for reason of instrumentation. If you do not have appropriate instrumentation, this does not give you enough visualization of the glenohumeral joint. So I tend to do an L split where you would do the transverse and a little L, not as long as this, so that I can have a flap flipped over and I can see the glenohumeral ligament. With stay sutures, I know where these are, and then I can close them back when my procedure is over, and not lose the integrity of the subscap. Structures at risk when dealing with the deltopectoral approach include the cephalic vein, and sometimes we nick it. You try not to, sometimes you nick it. What do you do if the cephalic vein is transected? We just simply ligate it. Double ligation, and that's fine. The tributaries will suffice. There may be some degree of edema in the postoperative period, but that would abate over time. The second structure at risk is the musculocutaneous nerve, which lies below the coracobrachialis, about 5 to 8 centimeters inferior to the coracoid, the tip of the coracoid. And retractors, injudicious use of the retractors around when retracting the conjoint tendon can damage the musculocutaneous nerve. And then, of course, the axillary nerve can be damaged at the inferior border of the glenoid, and as well as when dealing with the subscap muscle. The next approach we'll talk about is the lateral deltoid splitting approach. And this, as the name implies, just splits the deltoid. The lateral approach splits the deltoid. It gives you exposure to the lateral aspect of the humeral head, as well as the rotator cuff. Not all of the rotator cuff, particularly supraspinatus. It is not extensile, even though you could, with a skin bridge. And what's at risk here is the axillary nerve, which curves around the humeral shaft about 8 centimeters, 5 to 8 centimeters distal to the acromion. It's indicated for cuff repair, particularly the supraspinatus when you're doing the mini open. For the greater tuberosity fractures, as well as maybe simple two-part proximal humeral fractures. More extensive fractures should be dealt with the deltopectoral approach. And in the absence of superior cuff muscles, a reverse TSA can be done in this approach. Again, also, you'd use a modified beach chair approach. 5 cm skin incision from an anterolateral tip of the acromion goes down inferiorly. Take the subcutaneous tissue, and then you find the deltoid. What it is advocated is to put a stay suture 5 cm distal, so that you don't inadvertently propagate your split of the deltoid and injure the axillary nerve. And one is to look for the raphe, which gives you a bloodless area between the anterior part and the lateral part of the deltoid, and then split. Once this is split, what you will find is the subdeltoid bursa, as well as the proximal humeral bone. And what then you need to do is to address the indication for which the surgery was carried out. It's important to note that the axillary nerve can be injured by retractors, can be injured by the deltoid splitting further than the level of your incision. So always put a stay suture at the lower part of that deltoid split. So we talk about the arthroscopic approaches, and this has dramatically changed surgical approach to the shoulder, particularly in resource-rich centers, resource-rich places. The indications are ever widening, and then more and more things are being done with the arthroscopy. It has a steep learning curve. Usually would advocate that you learn to do a knee arthroscopy first before attempting the shoulder arthroscopy. Requires expensive equipment as opposed to the open approaches, and you would require equally expensive consumables for the surgeries. However, there's a quicker recovery. So typically you can do shoulder surgeries and patient goes home same day or the next day. So I have seen two patients in which I have two patients in which I've done subacromial decompressions and cuff repair for. One was an open, and one was arthroscopy. The arthroscopy patient went home the next day. The open surgery had 4 days stay in the hospital. However, outcomes were similar at the end of the day, but point still remains that recovery is much faster with the arthroscopic approaches. Indications will be instability, rotator cuff repairs, subacromial decompression, biceps tenodesis and tenotomy, slap lesions, loose bodies, arthrofibrosis with joint stiffness. And you also have, in cases of calcific tendinitis and the like, can all be addressed with the arthroscopic approach. Positioning, there are two positioning done, beach armchair and lateral decubitors. Which is better? The answer is in the air. What I find is that people do what they're comfortable with or what they have been trained with. In my center with the lateral decubitors, we actually started off with the beach armchair. Was just difficult. Lateral decubitors is easier for beginners and easier in resource-poor environments. It's also, the beach armchair has the advantage that is anatomic, and if you want to convert to an open procedure, it is easy for you to do without having to change the position of the patient, as opposed to the lateral decubitors. However, there is a trick to the lateral decubitors, which you do a 20 degrees posterior slide of your lateral decubitors position. That allows for, if you want to do a mini open cuff repair because you are having difficulties doing an arthroscopic cuff repair, you can then easily move into a near supine position and carry out the surgery. The beach armchair has the other downside of the cerebral hypoperfusion. And so you need to have a very experienced anesthetist, and so that you do not have that complication occurring. The lateral decubitors position, I would love to show you the image, but I couldn't find the image of one we've done. Patient is a typical lateral decubitors position, and then you have the arm, affected arm, abducted and elevated in a 15 and 45 degrees, 45 degrees elevation and 15 to 20 degrees anteriorly. and with a weight attached to that arm, up to a maximum of 5 pounds, which is about, so up to a maximum of about 4 kg, depending on the individual. So more bulky people, you'll use more weight, less heavy people, you use less weight. You need to put that in consideration because of the risk of brachial plexus neuroplasia. Most patients will recover, but that's not a complication you want to deal with post-surgery. These are the portals, and I'll look at the starting portal is written P. So for doing shoulder arthroscopy, you must mark the shoulder so that you know the positions of all the structures in the shoulder. And this looks at the spine. This is the spine of the shoulder all the way to the acromion, and that's the acromion there. Okay, it's marked there. That's the clavicle coming. So this is the anterior aspect of the patient. That's the posterior aspect of the patient. That's the clavicle marked there. This is the acromioclavicular joint. And then you now mark the coracoid process, and this will be coracoacromial ligament. And then, so the X's are where the potential portals are. The starting portal is the posterolateral corner, in which you will go 2 cm inferior and 1 cm lateral, sometimes 1 cm medial, to the corner of the acromion. Typically, you are expected to infiltrate this area with adrenaline so that there's a little bleeding. Unlike the knee joint where your trocar, your knife goes straight into the joint, here the portal is made by a skin incision only. And then by blunt, not dissection, but bluntly push the trocar directed at the coracoid anteriorly. When you do that, you would aim into the glenohumeral joint, and you feel a typical give as it gets into the joint. Once that is done, the typical thing is to then start to distend the joint. But the advice is to use air as a distension agent, because sometimes you're not in the glenohumeral joint, but you're in muscle. And if you keep distending with fluid, sooner than later, this whole area will be swollen and makes your surgery more difficult and makes post-operative period even more difficult. So the initial approach is, once you are in, inflate with air 50 cc in, and then put in your camera, your telescope, and have a look. If you're in the joint, then start to distend. Okay, I'll still come back to this image as the anterior portal, which I'll show you again here. That's the anterior portal, is done under direct vision, and you stay lateral to the coracoid. The maxim in shoulder is medial to coracoid is bad. That's where all the evil is. Lateral to the coracoid is good. That's where you're safe. Whether you're going open or arthroscopic, stay lateral to the coracoid. So you see, this portal is placed lateral to the coracoid. And this is your walking portal, your initial walking portal. You use a spinal needle, and what you do is to aim for the rotator interval. What that does is that when the spinal needle comes in, it will come inferior to the supraspinatus, but superior to the subscapularis muscle, whilst staying lateral to the coracoid. And because you're viewing from the back with the posterior portal, you will see this needle as it comes in. Once you're safely there and you're happy with it, you use an 11 blade to widen that and introduce a cannula, and that becomes the walking portal for you to work. In this image, you would see that is a biceps tendon, it's very inflamed. And you can see we're looking from the posterior portal, that's coming from the anterior portal, and that is a shaver, and you're like debriding the biceps tendon all the way down to the superior labral region. And that is coming from the rotator interval. Okay. So that's just a debriding process that is going on from the anterior portal. And most of the surgery you will do can be done safely with these anterior portal. Your instability surgeries, your slap lesions can be done through these portals. Okay. We also need to mention the lateral portals, because if you're dealing with a cough, the anterior portal will not suffice. You need to come laterally to put portals there. And these portals are aimed for the cough repair as well as subacromial decompressions. And they are anterolateral and posterolateral portals. You usually are 2 cm distal to lateral border of the acromion, and then you then go 1 cm anteriorly or 1 cm posteriorly, as the case may be. Avoid extreme distal portal because of the artillery nerve. I'll go back to our initial diagram there, and that's your anterolateral and posterolateral, or some people call it direct lateral. So through these portals, don't forget that this is still your viewing portal, and you will be able to direct it into the subacromial space. You will see your spinal needle coming, and then the same way you made the anterior portals, you make these portals. Needle, widen it, put your cannula, and then your instruments come in. And then from here, you can then do a subacromial decompression, that is, take out, do an acromioplasty, a bossectomy, and then you can then also attempt to address the cough. Okay. Other portals, and this is important in arthroscopy because you are allowed to make as many portals as possible. Once you've made initial viewing portals and working portals, you can make any other portal to improve access and allow you able to reach the structures that you need and properly address the problems that you're dealing with. And so the other portals are also named with respect to the arthroscopy. There's the posterior inferior lateral portal, which helps you to get into the infraglenoid access and allows you to address a Bankart lesion if you can't come in through the anterior. There's an Aversaire portal, which is a suprascapular portal where you will address a slap lesion. You could also do an anterior inferior portal. So you've gone anteriorly, you have that instrument coming in anteriorly, like so, that we described earlier, but you're not able to get to the anterior inferior aspect of the glenoid because that's where the Bankart is and that's where you're doing your repair. You can, under direct vision, come inferiorly and make that portal. And then there's a port of Wilmington, which is useful for suture anchor placement when doing cough repair. Okay, so conclusion. The knowledge of relevant anatomy makes all of these approaches a lot easier, and you need to tailor your approach, whether open, mini open, or arthroscopic, to the indication, as well as to the skill sets and equipment available to you. And we need to also know that the arthroscopic approach is increasingly in use in orthopedics. Thanks for listening.
Thank you very much, Dr. Itakwe. May I ask Dr. Labi to just unmute himself and moderate the Q&A session?
Anyway, okay, level is going up, bottom line. So, yeah.
Yeah, hello. Good afternoon. Good evening, all. Good evening, all. Can you hear me?
Good evening, sir. I hear you, sir.
So are you saying
Thank you so much for the presentation, Dr. Itakwe. He has really done justice to the topic, as we can all see. I would like us to indicate, to either type our questions on the chat board or to raise up our hands so that we can be called upon. someone is asking a question. The difference between beach chair and modified beach chair. Dr. Itape, you can please take note. Also, the difference in symptoms or clinical findings of compression of supraglenoid notch and spinoglenoid notch. The questioner equally wants to, is also asking that you should please kindly review your preferred technique for subacromial injection. Then he's also saying that fellowship, is there any fellowship opportunities in your center? And also, are there suggested reading materials for those who are interested in arthroscopy? Making 5 question. Let me go over it again. Difference between beach and modified beach chair, difference between symptoms and clinical findings of compression of supraglenoid notch and spinoglenoid notch. Then your preferred technique for subacromial injection, and whether there are fellowship opportunities in your center, then suggested reading materials. I've not seen any hand raised.
Okay,
I think you can, yeah, you can address that. Yeah.
Okay, so let's start with the subacromial injection. So really, you'd want patients seated. The clinic procedure. You can either go through the anterior approach or the posterior approach. The easiest is the posterior approach, where you would feel for the acromion, the posterolateral corner, and go 1 cm below that, and then needle in direct medially. But do not forget that the impingement is actually an anterolateral impingement. So if all of your drug is in the posterior aspect, then it's probably not doing much. So you would want to do the anterior approach, which is to feel for the clavicle all the way to the acromion. So that's the AC joint. And then feel for the acromion, and then anterior, just 2 cm inferiorly to that is where you would go in, take your needle in and point medially, and that goes into the subacromial space. It's a potential space and should be able to take up to about 10 mils of your injection. And of course, post-injection, you test range of motion to see how that works. With regards to the suprascapular nerve impingement, where you can have a spinoglenoid notch or suprascapular notch impingement. Like I said, if the impingement is at the suprascapular notch, it will involve both the supraspinatus and the infraspinatus. So you would have problems with elevation, okay, as well as internal rotation. But if it is just what's that thing called? What is the spinoglenoid notch? Then it's only the infraspinatus that's involved. The weakness is only of the infraspinatus. The atrophy is only of the infraspinatus. Okay, so that's where that difference lies. With the beach chair, in the beach chair position, patient is almost seated. Okay, the modified beach chair is just a supine with the head elevated, or the upper body elevated about 20 degrees. The beach chair position, patient is almost 90 degrees seated. So there's a big difference between the beach chair and the modified beach chair. Well, or probably will have said supine position with a sandbag underneath the scapula. That's probably what will have been the description. Fellowship opportunities in arthroscopy in my center, yes. We are always open to people coming to Igbobi. A lot of guys have come in and come and shadow us, basically. Just watch what we do, follow us around. I know that Latu Dr. Labi would be glad to have people come over. So there are opportunities in arthroscopy to do a lot of knee work and some shoulder arthroscopy and ankle arthroscopy. I think those, your hands will be wet with them. In terms of suggested reading material, I think for postgrads, your Chapman, Woods, and Campbell would suffice. It's when you're going to fellowship, then you then need to go into the nitty-gritties and details. Virtually everything I've spoken about today are in the regular postgrad texts. Maybe not in details, but they're all in the regular postgrad text. Dr. Alabi, do you have any additions?
Yeah, thank you. I want to see if I can share my screen. I have, okay. Just to make some clarification to the man asking the question on the beach chairs, you know, you try to show the pictures, but probably, so maybe when they see the pictures, they could have, yeah. Some of these pictures are actually that of Associate Prof. Bancha Chanchojit of Thomas University Hospital, Thailand. Some of them are also mine. This is the lateral decubitus position. And just as Dr. Itakwe mentioned, this is keeping the arms at around 45 degrees to the body. The patient is not lying completely lateral, he's tilted a bit posteriorly so as to make the glenoid surface to be horizontal, just about 20-25 degrees posteriorly. This is the proper beach chair position. This guy wanted to have rotator cuff reconstruction. You know, you can do this with the regular operating table, but the patient has to be reversed. You place the patient on the leg panel. The head will be on the leg panel, while the head panel will now accommodate the limb. So, and one half of that leg panel is depressed so that you can have more access to the shoulder on that side. But other facilities have an attachment to the bed to actually create a proper beach chair position. And you know, this is very good when it comes to walking around the shoulder, and you need to have equal exposure both posteriorly and anteriorly. And just like the doctor mentioned, your anesthetists have to be on top of their game because of the cerebral hypoperfusion that goes with it. This is what he was trying to describe as the modified beach chair. You can see that this guy is lying supine, but some sandbags or cloth or whatever are used to prop up the shoulder a bit and couple with the weight, and also taking advantage of the putting the head on that leg tray also helps to create, you know, to free some space, you know, around this place, thereby making it easy to easily convert to open if need be, unlike how one will have struggled if he was using the lateral decubitus approach only. Then I also think that some of those things you mentioned also, for the benefit of those, you know, you showed them using the MRI, for the benefit of those who probably have not seen more arthroscopy being done. Once you enter into the shoulder, you will know you're in the shoulder when you see the long head of the bicep. This is the long head of the biceps attached to the superior glenoid region and the labrum. This is the head, and of course this is the glenoid, and this is the labrum there. You also dwell significantly on the glenohumeral ligament, the inferior, the middle, as well as the superior. Then these are very important things that one needs to have a clear vision of while in the joint, because we're talking about arthroscopic anatomy. And just like you mentioned, the sublabral foramen, these are normal findings. So this should not be mistaken for a labral tear. Otherwise, one will be repairing what is not done. You clearly demonstrated that using the MRI. I just felt showing the arthroscopic view will also kind of drag home the message, and also as well the sublabral recess. It should also be noted that there is a normal thinning of the middle of the glenoid. So don't take it for osteochondral lesion. So if you look at the normal glenoid, you will see areas where the cartilage looks to be very thin. It is not a lesion, I mean, it's not pathologic. That is the normal thing. The periphery have more cartilage volume than the center of the glenoid. And just like you also mentioned that the rotator cuff, the cable, and they prevent proximal migration of the head. And that is why when you check the radiograph, you want to see how far is the head from the acromion. Once getting less than 8 millimeter, it's an indication that the patient could be having a rotator cuff, problem. Also, one should also note that on the inferior part, there is this bare area. Bare area should also not be mistaken for osteochondral lesion. It shows it's a clear space between the articular surface and the capsular reflection where we have the infraspinatus attached to. So that should also be taken note of. People have talked of the pulley system. I think Dr. Itakwe has done a lot. These are some of the pictorial representation of what one can expect when you enter into the joint. Then for those who have any repair, if there is no repair, you see something like this. If you go into the proper subacromial space, but following repair, it looks something like this. By and large, I think he has touched most of the things. I only try to augment with some pictorial
Thank you.
representation.
Thank you,
Yeah.
Dr. Labi.
Yeah.
You've made my job a lot easier. I have a
Yeah.
question actually. In your experience, what approach what position do you prefer? Is it the beach armchair or the lateral decube, and why?
Yeah, it depends on what I'm doing. If I am just doing a straightforward bankers repair, maybe I'm using Kaspari's technique, I use the lateral decubitors because it's pretty more straightforward for me. But if I need to see the glenoid more, then I go for the beach chair, the beach chair position, because with that, I can be able to use a Kim spotter. A Kim spotter is also like a posterior porter, but it's more of a posterolateral than posteromedial. So when one take about 1 cm anterior to the acromion, but about 1 or 2 cm inferior to the acromion, as you enter, you are looking directly on the glenoid. So for patients who have both Bankart and reverse Bankart lesion, so that one can be able to
Both
address,
anterior and posterior.
both sides.
Okay.
Yeah.
Thank you.
Thank you. Yeah, can we have more questions, please?
Dr. Labi, there was a question for you,
Okay.
which I put in the chat box. It was concerning one of the pictures you put up.
Okay. Can you please read the question for me? I'm trying to.
Okay, it says, picture illustrating the beach chair position by Dr. Labi. I noticed that the lateral lower extremity was also prepped. Why is that?
Okay. Yeah, that's like I said, I didn't mention that that patient was to have rotator cuff reconstruction. You know, when rotator cuff when we have massive cuff and the surgeon fears that one will not be able to drag the cuff to the footprint on the proximal shoulder appropriately, or there will be too much tension. So we sometimes use the tensor fascial lata. So we prepare the limb, prepare this, and what is done is an incision here just below the GT. The tensor fascial lata is thicker immediately after the GT compared to other parts of the body. So one will harvest based on the size of defect to be covered, right? One can harvest as much as 4 by 4 centimeter. Then one can close primarily back, then create a tunnel using the lateral portal as described by Dr. Itakpe. Then one can actually drag in the graft. So the graft can be dragged in arthroscopically, then we'll now attach the proximal part of the graft to the remaining part of the rotator cuff, while the rear part will now be fixed to the humerus. And what that does, what it does not actually carry out all the functions of the rotator cuff, but it creates that cushion between the head of the humerus, the proximal humerus and the acromion. And so once there is that cushion, the impingement problem that the patient, and symptoms that the patient have is significantly abated. And that has worked well for some of the patients who had that while I was in training in Thailand. This is actually one of the patients. Actually, I was in this suit when this picture was taken. Let's check if there are still more hands up. Okay, I also want to say something on the deltopectoral approach. Apart from what Dr. Itakpe described on how to deal with the subscap, we also have surgeons who take a flake, of the subscapularis. Following those surgeons almost always removes the long head of the biceps. They will do tenodesis of the long head of the biceps, based on whether the patient is young or patient is old. When they are coming out, they will do a tenodesis or just leave it like that. Because if you just leave it, a patient will develop bicep bump, which they feel in elderly doesn't make anything. But for young patients, it may make, they may be concerned of that. So having removed the long head of biceps from the groove, one can place an osteotome facing the lesser tuberosity and take a flake. That area where the subscap attaches to, you take a flake of bone with the subscap, and that allows you to flip the whole subscap to the other side, especially if one is doing maybe a primary total shoulder replacement or a reverse shoulder. You need that exposure because the humerus will need to be a maximal external rotation while you are putting your stem. You don't want to cause more trouble, especially if one has to use cement. So having done that, on coming back, that can be replaced back with some special suturing technique. One will now make a drill hole onto the greater tuberosity part, and with those holes, an array of, let's say, about 3 or 5 sutures can be used. And when that is adequately knotted, it prevents development of non-union under the flake of the bone, because subscap is a tendon that, as you move the shoulder externally, internally, you are going to be removing it. So if that repair is not solid enough, there may be micro motion and that flake may not unite. But so far, for all the ones that have been part of, I think it has done very well. They've all healed, and it gives a better exposure than trying to remove part of the subscap or trying to split it. And at the same time, there is no morbidity that will have happened if one has done something like it's been done in Putiplat. So one should also take note of that you can do that apart from those other options that Dr. Itakpe had mentioned. Also a note on this subacromial injection for thick patient. I mean, when patient is obese, it may, depending on where the pain is, if the pain is close to the acromioclavicular junction, it's better to go anterior. But for a slim patient, either anterior or posterior, one will always get the substance delivered at the right place. And so all those advice given by Chief Itakpe is actually they are essential. And also, one should also know that in pectoral approach, apart from removing the long head of biceps, sometimes one may need to relax some of the upper fibers of the pec major to have adequate exposure, because not having adequate exposure predisposes one to having periprosthetic fractures or having some difficulties during surgery. One will not release the whole of the pec major, but the upper fibers can be released. And when that is done, the whole thing just suddenly opens up, and it helps while using that approach. Are there further questions?
I don't think we have any further questions.
Okay. So I hand over to the chief moderator.
But I think a question just popped up now. Kemi,
Oh,
I think a question just popped up. You want to have a look at it?
The last question here was 5:21 p.m. I can't see anything after that. So maybe it popped up on your own screen.
You can please help us to read out the question, Chief Sobode, if you are saying it.
Okay.
I think the question has been addressed.
Okay. I think he has addressed in the picture illustrating the beach chair position.
It's been addressed.
Yes. Well, just to say that next week we'll continue with hip pathologies, and we're going to inflammatory degenerative conditions and infections on the 15th. And we should have a session on grant and proposal writing on the 16th. And I do hope we have quite a good turnout. I'm particularly excited about the grants and proposal bit, because I think this is how we need to learn to get funding for our work, and that would help us to be able to get more done and get more information and knowledge for our patient care. I don't know if there are any other questions, any other comments, or we can start proceeding towards closing the meeting.
Yeah, I have one comment, Anikemi. Personally, I would love to, before you thank him, I would love to thank Itakwe. I know it's very difficult getting a big masquerade like that out to give a lecture, and we hope to see more of him. Is one of the best around, so we should we stand to gain a lot having him speak to us all the time. Dr. Itakwe.
Dr. Shuboti, this flattery does not work.
This is not flattery. It is saying it the way it is.
This flattery does not work.
This is not change 2019. This is real. This is real.
Okay. You're far too kind. Actually, I'm happy that Dr. Labi was here to share his own wealth of knowledge, and it was quite educative, the things he pointed out. So I'm glad I'm here, and I learned a bit too as well. So hopefully I'll be at the next available session for us to share ideas again.
That's very heartwarming. Thank you so much. And Dr. Alabi,
Yes, sir. Chief Shobode.
you remain my chief forever, sir. Thank you very much.
Thank you.
Yeah.
Thank you, Chief Itakwe. It was very, very, very an elaborate talk.
Thank you, sir.
You. Yeah, thank you so much.
Well, nothing more to say except that Dr. Shobode has said it all. I was just starting on the Oriki of Dr. Itakwe when you started. Thank you very much, Dr. Itakwe. And we will see more of you, plenty of you, and we're very excited about that. Particularly, I do hope the residents would just, read and try and find their way to your operating theater one way or the other, just so that they can actually see these things. Because I always found arthroscopy very, very abstract until I saw a few cases done. I just couldn't wrap my head around reading it, to be honest. So next week is another date. We'll start off Saturdays and then Sundays, same time, same station. Come one, come all. And please bring your colleagues as well. Thank you so much again, Dr. Itakwe. Thank you for a beautiful lecture. Thank you, Dr. Alabi, for your comments and for your wonderful moderation of the Q&A session.
Thank you, ma'am.
Hope you all have a lovely week.